Thanks.
Thank you, sir. Respected seniors, dear friends, good afternoon, everyone. My topic is on deceased donor transplantation, organ retrieval, preservation, and their allocation. It's a very big topic. I will just give an overview of this topic. In 1954, we witnessed first successful kidney transplantation among the identical twins in Boston, and the surgeon, Professor Murray, got the Nobel Prize. The recipient survived for about 8 years. In India, first kidney transplantation was performed in KM, Mumbai, from the deceased donor, and recipient expired after a few days. First successful rival-related transplantation was performed in CMC Vellore in 1971. Over the last 5 decades, we have seen tremendous advancement in the field of transplantation, both live-related and also deceased donor in India. But there is always a demand-supply mismatch, not only in India, but across the globe. Many people are dying because of organ shortage, and many people are awaiting for a deceased donor in the wait list because of shortage of live donors across the globe. In the West, deceased donors contribute to maximum number of transplants to the tune of 70%. And in India, live donors contribute to maximum number of transplants to the tune of 80 to 85%. If you see this diagram, only few states, especially from South India, they are very actively involved in deceased donor transplant program. And in some parts of the India, even this program is not yet initiated. So there is still a long way to go, especially with related to deceased donor transplant program. If you see the organ donation rates in India, it's much less compared to various other countries, especially the Western countries. We follow opt-in policy, but I am proud to say our Telangana state, we have, over the last 1 decade, there was tremendous improvement and advances in the field of deceased donor program. And last year, in 2022, just we calculated last month, our deceased donation rate was 5.72 in 2022. And we stood number 1 in our country in number of deceased donations in last year. This is a bar diagram showing the upper left, showing the number of kidney transplants. And if you see, almost 85% of them are from live donors, and deceased donor contribute to only less than 15%. And if you see the lower right, this is the deceased donor donations, and most of them, they are from brain death donors, and cardiac death donations are just you count on fingers. Mainly IKDRs and PGI are doing these types of DCD donations. The key elements are of any deceased donor program is identifying, it starts with identifying a potential donor and ends with organ harvesting, preservation, transportation, and finally transplantation. Many people are involved in an active deceased donor program, and everybody should be on toes in the middle of night to get a successful deceased donor transplant. If you see the types of deceased donors, we have brain death donors and cardiac death donors. Most commonly, it is brain death what we utilize. These again standard criteria and extended criteria donors. In case of donation after cardiac death, as per the Maastricht classification, it's categorized, and most commonly category 3, that is controlled cardiac death donors, are most commonly utilized after withdrawal of life support. India legalized brain death after passage of TOTA Act in 94, and latest amendment was in 2014. Before brain death certification and declaration, various prerequisites should be met before actually going for the neurological examination. Apnea test should be performed, and it should be positive at least twice, at least at an interval of 6 hours. And various ancillary tests are available, especially if the apnea test is equivocal or where it cannot be done. This is again the same flow chart. I will not go into the details because of lack of time. Optimal deceased donor management is crucial in any program. It affects the quality of organ retrieval, number of organs retrieved, the final graft function after transplantation, whether it is going to be a delayed graft function or primary non-function, it all depends on optimal deceased donor management. Brain death is a state of altered physiology with systemic inflammation, complement activation, coagulation system, and various endocrine changes. All these need to be monitored and optimally managed. These are the elements of deceased donor management. Endocrine management is also very important, especially tackling central diabetes insipidus, replacing thyroid hormone. All these are very important. There is an app from Mohan Foundation which helps as a quick reference guide at the bedside. One can download it. Documentation is very important in deceased donor transplantation. The overall outcome of these transplants depends on the cause of death, use of inotropes, presence of infection in the deceased donor, presence of comorbidities, the quality of organ perfusion and storage, transportation, and warm and cold ischemia times. All these need to be documented properly for the better outcome of the patient. The principles of organ harvesting between brain death and cardiac death donors are slightly different. Brain death is the most common form of deceased donation, what we see in India. The hemodynamics are to be maintained by use of IV fluids and vasopressors. Vasopressin has a dual advantage as it treats central diabetes insipidus also. In brain death, warm ischemia time is not usually prolonged because the circulation is intact. But if you are planning a multi-organ harvesting, starting with heart, lungs, then liver, pancreas, and finally kidneys may be at risk of higher warm ischemia time. So it's a proper coordination with multiple surgical teams is very essential in these cases. And usually after organ retrieval, these are perfused in vitro after removal of organs from the human body. And cytokine storm is actually much more common and severe in brain death compared to the cardiac death. And this can affect the expression of inflammatory molecules in the graft tissue, which again affects the risk of rejection. In case of cardiac death, it's actually much more popular in West. In India, it's still in infancy stages, and controlled cardiac deaths are most commonly utilized. There is a category 3 matrix classification. As there is cardiac asystole, warm ischemia is much more in these cases, which again affects the graft function following transplantation. And there is a specific no-touch period following asystole before organ retrieval, and this is usually 5 minutes in majority of the countries. Few countries, they follow 10 minutes rule. And if it is uncontrolled cardiac death, where the cardiac arrest is not precisely known, cardiac massage can be done by using various instruments. And here, usually, the perfusion is done in situ after inserting large perfusion catheters into the great vessels. Coming to the few points with relative harvesting of kidneys, arteries are harvested along with the cup of aorta usually, and maximum length of the renal veins are usually harvested, especially on right side. IVC cuff is also taken out. If it is a short renal vein, usually there is risk of kinking of arteries after transplantation. In case of left renal vein, need to take care of 3 tributaries, that is lumbar, adrenal, and gonadal. And ureter around 10 to 15 centimeters is usually taken out. If you take care of all accessory arteries, especially the lower pole artery, which also supplies to the ureter, and all these arteries are end arteries, so they should not be sacrificed as much as possible. And reconstruction can be done if there are multiple vessels like double painting, etc. And excess donor tissue need to be removed, because more the donor tissue, more the immunogenicity, but need to take care of golden triangle, the angle between the lower pole of kidney and the ureter, and the adventitial tissue of the ureter should not be dissected much because it compromises the ureteric blood supply. Need to take care of lymphatics, and few surgeons, they practice venous clamp technique, where during perfusion they clamp the venous side, renal vein, to look for any leaks from the surface of graft or from the vessels, and they repair if there are any tears. These are the experiences of DCD donations from IKDRC and PGI. There was a position paper which was published last year from various experts across the nation regarding DCD donations. Coming to the organ perfusion and preservation, it plays a crucial role for maintenance of vitality of the organ once they are out of the human body, and it marks the beginning of cold ischemia time. Various physiological changes happen once the organ is out of the body, and this affects the viability of the tissues, and various components of perfusion fluid mitigates each of these physiological changes. These are commonly used perfusion fluids. The first solution was choline solution, but it lost its popularity because it contained glucose, which led to lactic acidosis. It was replaced by mannitol in urocholine solution, but various trials have shown that urocholine has inferior outcomes compared to the currently used solutions. Citrate-based solutions are commonly used in European countries. It chelates calcium. Balanced salt solutions, including Ringer's lactate, is commonly used in developing countries, especially for live donations, even in India. The two most commonly used solutions are University of Wisconsin and STK. University of Wisconsin is most commonly used in US. STK solution is used in developing countries, including India. Histidine acts as buffer, whereas tryptophan and ketoglutarate acts as substrates for metabolism. These are the components of all these solutions. Because of lack of time, I will not go into the details. These are various randomized studies which compared different solutions, and the final conclusion of all these trials is urocolins has inferior outcomes to the both STK and University of Wisconsin, but one study has showed that STK has inferior outcomes to the UW solution. There was a meta-analysis which again concluded that urocolins has inferior outcomes, but there was no significant difference in between STK and UW solution. Coming to the methods of perfusion, it can be in situ perfusion, as I told, where before organ harvesting, organs are perfused within the human body, especially to reduce the warm ischemia time. This is especially used in DCD donations or whenever you are planning for multi-organ harvesting in a brain death patient. Static cold storage is the most commonly used method in developing countries in India. And hypothermic machine perfusion is gaining popularity, especially in the West. Normothermic perfusion methods, either regional method or a machine perfusion method, is gaining popularity in UK and other European countries for DCD donations and extended criteria donors. In situ perfusion, large vessels are punctured with perfusion catheters, and balloons are inflated proximally and distally, and perfusion is done in situ before organ retrieval. This was the first machine perfusion unit that was developed by Belgium. It's a like cumbersome unit, but the latest machines, these are the three commonly used methods in Western countries. Normothermic regional perfusion is the principles are similar to ECMO. These are commonly used in UK for disease donations, DCD organs. These are the studies supporting the use of this method. Various randomized studies, they compared static cold storage versus hypothermic machine perfusion, and except the first UK study, all the studies favored actually HMP method compared to the static cold storage in reducing DGF rates. There was a meta-analysis which again concluded that HMP, hypothermic machine perfusion, is with lesser risk of DGF compared to static cold storage, even though there was no difference in overall graft outcome. Coming to how do you select a specific fluid or a method of choice, there's no consensus by any organization. It depends all on what is the organ type of the organ, what is the expected preservation time, and what is the duration of transportation of the organ. If you are expecting a prolonged cold time, University of Wisconsin is can be used. This is followed in US. If the expected cold time is less than 24 hours, citrate solution or Celsius solution is used. This is commonly used in European countries. If there is short cold time, STK can be used, which we are using in India. In live donors, one can use even simple Ringer's lactate solution. These are the ideal preservation times for different organs. This again affects the order of organ retrieval in a multi-organ harvesting procedure. Once the organs are, after static cold storage, the organs are packed properly in 3-bag technique. The first bag should contain organ submerged in the ice-cold preservation solution, and adequate de-airing should be ensured before tying. Coming to the organ allocation, there is no uniform allocation protocol that is proposed. Each country, even within India, each state has its own allocation protocol. These protocols, allocation protocols, are networking is to avoid organ wastage, especially for the precious organs like heart and lungs. There should be a balance between equity and utility when organ is shared. Equity means everybody has equal chance to get an organ from the deceased donor. Utility means those who get the maximum benefit are those who had the maximum survival benefit following transplantation. They should get the priority. So in all this allocation protocol, you should balance both equity and utility for the proper allocation. The commonly used criteria for any organ allocation protocol, not only in India but even in West, these are the points they see. So they score the patients on wait list depending on the duration of dialysis or the date of registration. There is a longevity matching, which we'll discuss in next few slides. with various scores, there is a HLA matching is given priority currently. If there is a zero HLA mismatch donor is available, it is subjected for national sharing, and different countries, they use different HLA loci matching for priority, and sensitized individuals are given priority. Prior living donors are given extra points, and blood group identical, usually the donor organ should go to the identical group rather than compatible group. Unless it is a HLA zero mismatch or highly sensitive recipient, then even compatible donor can be allotted. And certain countries, they use medical urgency criteria. Those who are not able to maintain on dialysis for longer duration because of access issues and all, they are given more priority. And pediatric candidates are given priority in few other countries. I will not go into the detail of how each of these countries, but we'll focus on UNOS, that is United States, few points about UNOS protocol. It's most commonly disease brain death donors they utilize, and the revised allocation policy was implemented in 2014. For donor, they calculate kidney donor risk index and profile index, and for the transplant candidate, they calculate the estimated proportion of survival, and they try to match both the things. HLA matchmaker algorithm is currently followed in European countries, which enables the HLA compatibility at the epitope or triplet level in contrast to the antigen level. So this identifies basically acceptable mismatches. So there is an acceptable mismatch program currently active in European countries. They do virtual cross-match whenever the donor organ is available. It requires high-resolution HLA typing for the both donor and recipient. KDRI, kidney donor risk index, is a relative risk. It indicates the risk of graft failure compared to the median donor. That means if the KDRI score is more than 1, it indicates that it has a higher risk of graft failure compared to the median donor in the previous year list of donors. KDPI is another way of expressing the graft quality. KDPI is basically a percentile scoring which ranges from 0 to 100. For example, if KDPI score of 80, that means it has a higher risk of graft failure, more than 80% of the donors that are recovered in the last year. So lesser the KDPI score, better is the quality of the donor organ. These are the points. This is an online calculator that is available to calculate the risk scores. Lesser the KDPI score, longer is the survival. This is a comparison of survival between the live donor and deceased donor with various KDPI scores. In UNOS, the kidney transplant wait list, if you see the eligibility criteria to enter into wait list is less than 20 ml GFR. For transplant candidates, they give various scores, especially estimated post-transplant survival score, and they also calculate the calculated PRA, which is a virtual score, depending on the number of HLA, unacceptable HLA antigens. And HLA, high-resolution HLA typing is done for both donor and recipient candidates. This is a CPRA calculator that is available online. If you enter the number of unacceptable antigens, it automatically gives you a score of calculated CPRA. Coming to the EPTS score, again, estimated post-transplant survival, it is also a type of percentile scoring ranging from 0 to 100. Example is EPTS score of 20, that means less than 20 means it is the candidate is in the top 20 in the list of survival. So candidates with estimated post-transplant survival score less than 20 are offered organs with the donors with KDPA score of less than 20. That means the good quality organ are allocated preferentially to recipients who have the maximum survival benefit. This is again online calculator for EPTS score. It's available online. Lesser the EPTS score, the better the survival for the recipient. There is also a mandatory sharing that is allowed in the United States, especially for the zero HLA antigen mismatch or when there is highly sensitized recipient. So these organs are subjected for national sharing, and even above compatibility is considered rather than identicality.
Dr. Praveen Kumar,
Just
how many more slides, sir?
2 minutes. In recent allocation protocol, they included even type B recipient to receive organ from non-A1 donor. As we know, A2 donors have lesser antigenicity. So they can receive, they can be allocated to type B recipient after proper consent. Coming to organ sharing in India, we have different systems in different states. We have Jivandan in Telangana state, and in India we have 3-tier system currently active. We have Noto as the apex center. We have 5 regional centers and we have different state centers. Our southern states come under Chennai Roto, and there is a scoring system that is proposed by Noto, but these are not universally accepted or implemented by all the states. In Jivandan, we have a separate scoring system for the recipients. These are the various forms from Jivandan. So there is a zonal preference followed by, if there is no intended recipient, it is shared across the state, then other states within the regional Roto and across the nation. This is especially useful for heart and lung transplants.
Kindly conclude, sir.
We had a maximum number of donation in last year. Our deceased donor donation rate was 5.7, as I already told you. In Gujarat, this is a very detailed model they are implementing for allocation. And just to note that in 13, they also included willingness for list exchange. In this, if the candidate is willing to accept, if they are ready to donate an organ from a live donor from the family, they are given extra points, that is 12 points.
Please conclude, sir.
So to conclude, conducting a successful retrieval and deceased donor transplantation program is often a race against the time. We need efficient coordination between multiple people, including government officials. I end this talk by thanking these people who helped me for this talk.
May I now request the chairperson to honor Dr. Praveen Kumar Ita with a memento.
Yeah, we have only one question, please. Actually, only one question because we are out of time. Okay, we'll go ahead with it.
Okay, thank you, sir. Dr. Praveen Kumar Ita, please come over to the stage. The next talk will be by Dr. Ilanjikal Ilyas John on monoclonal gammopathy of renal significance, treat or not beyond kidney. And the chairperson will be Dr. Chakravarti.